So this is the short video regarding the X-rays which are kept in the final year examination. Just see this X-ray before going for a examination. So just see this is the X-ray taken in standing position showing the right dome of diaphragm. This is the left dome of diaphragm, and the X-ray is showing this is the ear under the right dome of the diaphragm. So what is the diagnosis? So the diagnosis is the ear under right dome of diaphragm suggestive of pneumoperitoneum. So what is the cause for this condition? This is the condition is caused due to the bowel perforation. So this could be a bowel perforation. What are the clinical findings related to the bowel perforation? So this can be a signs and symptoms of peritonitis. These are the abdominal pain, distension, vomiting, and patient may be present with the signs and symptoms of toxic features like raised WBC count, fever, tachycardia, tachypnea, all that. And what are the indications or investigations for the diagnosis of this condition? So ideally, this could be diagnosed by the CT, contrast CT scan of the abdomen and pelvis. But in case of emergency, we can proceed to the surgery on the basis of clinical findings and the X-ray findings of the patient showing the ear under dome of the diaphragm and clinical findings suggestive of the perforation like guarding rigidity, and the patient is having features of uh, intestinal obstruction like vomiting, constipation since 2 to 3 days. We can proceed to the uh, treatment of choice. That is, treatment of choice is exploratory laparotomy if the perforation is at the prepyloric uh, prepyloric site, then the treatment will be Graham's patch repair. So this is all about the this X-ray. So we will proceed to the next X-ray. So this is what is this? This the X-ray is showing. So basically this is a pediatric X-ray, and X-ray is showing the two ear bubbles. So this is large ear bubble and this is another small ear bubble. This is one and this is two. So this is the X-ray showing the double bubble sign. So in which condition double bubble sign is seen? So the diagnosis or this condition could be duodenal atresia. So this is the first bubble is due to is stomach, and the second bubble is due to first part of the duodenum or a bulb of duodenum. So what are the causes for this condition? It can be a duodenal atresia or annular pancreas. What are the clinical features? Generally, patient may present with the bilious vomiting. Why? Because generally duodenal atresia is uh, distal to the ampulla. So it may present with the bilious vomiting, abdominal distension, inability to tolerate the feeds. So what is the investigation? So investigation will be X-ray and CT scan. Ultrasonography can be done in case of a ultrasonography could be a diagnostic in case of a congenital hypertrophic pyloric stenosis. So, but that in that case, the patient or X-ray will show single bubble sign. So, what are the causes for single bubble sign? It is due to gastric outlet obstruction. Triple bubble sign. Triple bubble sign is due to jejunal atresia. So, what would be the treatment for this? So, the treatment for the duodenal atresia is due to is duo duodeno duodenostomy. a diamond shaped duodenostomy is done, or in case of a uh, annular pancreas, or in case of a duodenal obstruction due to pancreatic tumors, the palliative surgeries like gastrointestinal can be done in case of a adult patient. And in pediatric, treatment of choice for the duodenitis is duodenostomy. A diamond-shaped duodenostomy is made from in first part of duoden to the distal to the atretic duoden. So this is all about this X-ray. So this is next X-ray showing the. So this is the next X-ray. It is showing the multiple air fluid levels in the center of the abdomen. So what is the diagnosis? So this could be a small bowel obstruction. So what are the causes of small bowel obstruction? So most common cause of small bowel obstruction overall is a post-operative adhesions, more common than the hernia. So what are the clinical features for the small bowel obstruction? So what are the cardinal signs of obstructions? Are the abdominal pain, vomiting, constipation or obstipation, and distension. In case of a small bowel obstruction, vomiting is profound feature, and in case of a large bowel obstruction, abdominal distension is a profound feature. So, what are the investigations? Investigations are X-ray, USG, and the CT scan is the investigation of choice for the diagnosis of the small bowel obstruction. And the treatment for the this is exploratory laparotomy. Plus, if it is due to adhesions, we can do adhesiolysis. And if it is due to hernia, the treatment should be according to the type of hernia. It can be internal hernia or it can be inguinal hernia. So, in case of that, we should remove the uh, sac, open the sac, see the condition of the bowel. If the bowel is healthy, it is kept as it is. If the bowel is unhealthy, showing the signs of gangrenous changes, then it should be a resected and the reanastomosis of the healthy bowel is done. So the next X-ray is, yes, this is the again multiple air fluid level in the center of the abdomen. So again, this is the case of a small bowel obstruction. So this is the small bowel obstruction. Yes. What is this? This is the another X-ray showing the bowel obstruction, but the bowel involved is not the small bowel. So this is the actually this is the large enlarged cecum. So this is the cecal volvulus. So what are the causes for the cecal volvulus? Generally, it is idiopathic or maybe associated with malignancy. So what are the clinical features of uh, large bowel obstruction? Are vomiting, distension, constipation or obstipation. So in this case, distension and obstipations are the profound features. So what is the investigation of choice? Investigation of choice for this is the CT of the abdomen. The treatment will be in case of the cecal volvulus, the treatment can be a conservative initially, but in case of a cecal volvulus, there is no conservative treatment available, or we cannot wait for a conservative treatment. So treatment should be exploratory laparotomy with a right mecolectomy. If it is a cecal volvulus, the direction of the apex would be towards the right upper quadrant of the abdomen. So in case of the cecal, it is towards the left quadrant of the abdomen, left upper quadrant. So yes, this is the next X-ray. Actually, it is a barium swallow. So barium is swallowed and X-ray is taken. It is showing a smooth tapering at the lower end of the esophagus. This is the G junction, and it is showing the narrowing at the lower end of the esophagus. So what is the diagnosis? So it is a smooth tapering at the lower end of the esophagus, could be due to Achalasia cardia. So the diagnosis is the Achalasia cardia. What are the clinical features of the Achalasia cardia? It can be a dysphagia, regurgitation, weight loss. This is the classical triad of the Achalasia cardia. What is the investigation? So investigation or gold standard investigation for the diagnosis of the Achalasia is esophageal manometry. What is the treatment? Treatment is that is the cardiomyotomy or modified Taylor's cardiomyotomy. If endoscopic treatment is OM, per oral endoscopic myotomy. It can be done in, and the good or best results for per oral endoscopic myotomy are seen in case of a grade or type 3 Achilles cardia, according to the recent guidelines. So the what is this? Yes, this is the next X-ray, and this is showing the radio opaque yes stone at the urinary bladder. This is the stone, the urinary bladder. So what is the diagnosis? Which is a bladder calculi. So what are the causes for the bladder calculi? That is mostly associated with the bladder outlet obstruction. So what are the causes of bladder outlet obstruction? It can be due to benign hypertrophic prostate, or it can be associated with the recurrent infections. Bladder stone can be associated with the foreign body like a prolonged catheters. So, what are the clinical features? Generally, bladder calculi patient present initially remain asymptomatic, and they have symptoms of UTI like urinary frequency, irritation, burning micturition, and symptoms of if the due to pressure in the bladder, it may leading to the back pressure and may cause a hydronephrosis or hydroureteronephrosis. In case of a complication, it can present as a hydroureteronephrosis or pyonephrosis. So what is the investigation? Investigation is NCCT, non-contrast CT scan, or NCCT KUB. We can diagnose the stone in case of a non-contrast CT. Then treatment would be, if the stone is small, can be removed by cystoscopic removal. If the stone is large stone, then we have to do a suprapubic cystolithotomy. Yes. So this is all about this X-ray finding. Another X-ray is this. What is this? This is actually a so what is this? This is actually a degestant. So the diagnosis is of foreign body in the X-ray showing double J stent, double J stent in or kidney. The causes it is placed after the surgeries of ureter or a bladder or a pelvic surgeries of kidney, like or for the drainage, hydronephrosis. So, what is the investigation or the treatment? So, it is actually a part of the treatment after the surgeries for the nephrolithotomy or surgeries of the removal of the stones from uh, the renal pelvis. After the surgery, the stent is placed to drain the urine and make to avoid the blockage of the urinary system. So this is the next X-ray. So what is this? This is the actually a large renal stone occupying the right renal pelvis. So it is a Staghorn calculus. It is associated with infection, mostly protease infection. What are the clinical features? Clinical features are due to the stone in the urinary, stone in the renal pelvis remain asymptomatic for a prolonged period, and then may present with the features of UTI like burning maturation, and it may have features of hydronephrosis or pyelonephrosis. Investigation and non-contrast CT, AUD, and treatment. If for this stone, large stone, nephrolithotomy is done, or if the stone is small, PCNL is done, percutaneous nephrolithotomy. Ideally, PCNL is done if the stone is cannot be removed from the PCNL, then nephrolithotomy can be done, nephrolithotomy or pyelolithotomy. So what is this? This X-ray is showing the normal urethral anatomy. Is this? This is the urethra. The contrast is pushed by the syringe and X-ray is taken. So what is it? This is the retrograde urethrogram. So it is used to diagnose the urethral stricture. So what are the parts of the urethra? So this is the penile urethra. This is the bulbar urethra. This is the membranous urethra. And this is last one is prostatic urethra. Actually, this is the posterior urethra and this is the anterior urethra. So this is the X-ray showing the normal anatomy of the urethra. So this is the retrograde program. What is this? Yes, this is a CT scan, actually a plain CT scan of a brain showing the yes hemorrhage on this side. This is the concave shape. Concave shape hemorrhage on the this side. This is due to diagnosis could be subdural hemorrhage. Is a SDH. So the cause could be trauma. Clinical features are headache, blurring of vision. A patient may be loss of consciousness, vomiting, What is the investigation? Investigation of choice to diagnose the HDHS and CCT head. Treatment is depending upon if conservative treatment is failed or very large HDH is placed in the midline or midline shift is there. Patient is not uh, responding to the conservative management, the treatment yeah, for whole surgery. So this is the temporary treatment. So treatment should be craniotomy treatment of choice. So next is yes, this is the NCCT head showing convex shape hemorrhage on the right side. So this is the ADH. This is the extradural hematoma. Common causes trauma. Clinical features are same like that. ADH like headache, vomiting, uh, then blurring of vision, loss of conscious. Special feature in the ADH is that initially patient has gone into the having loss of consciousness, then become conscious and again become rapidly deteriorate, have loss of consciousness. So this is the interval that is known as this is as a lucid interval. In that interval, patient feels or appears healthy. The patient is conscious oriented with less percentile, but due to the underlying uh, hematoma compressing the midline, it causes herniation of the brain, and the patient may end up with severe uh, brain damage and may lead to a death. So, the patient in this lucid interval, patient should not be discharged and sent for a home, thinking that it is a normal patient. So, investigation is NCCT. Treatment is again bore hole surgery or craniotomy. Actually, craniotomy is the treatment of choice. Bore hole surgery is a emergency procedure just to remove the hematoma. So this is the CT scan showing the this is the EDH. This is the EDH. Yes, what is this? What is this? This is the X-ray of a child, and see this is the rice tube. The rice tube is put, but it is again coiled and it is again come into the mouth. So unable to put a rice tube. So this could be a due to a tracheoesophageal fistula. This is the tracheoesophageal fistula. The cause is that it is a congenital anomaly. Clinical feature is patient may present with a respiratory problem, let's say respiratory dyspnea, and then drooling of the saliva, and then if we are putting a rice tube is coiling of the rice tube. Investigation should be this endoscopy, this bronchoscopy. So this is the investigation. Another case of fistula treatment is a surgical repair. Fistula has to be done. So this is the X-ray generally not asked it to the undergraduate. Just remember the name. So actually, what is this? This is the coin is placed at the sacrum of the child, and the X-ray is taken in the from inverted baby, right? The diagnosis of the X-ray finding it is actually invertogram. And in which condition invertogram is done? It is due to anorectal malformation. It is done to diagnose or locate the lower end of the anorectal malformation. So this is not done nowadays. Yes, what is this? Let's see. So this is the chest X-ray. These are the ribs. Actually, this could be the ear, complete lung field, but the actual lung is this only, and this is ear. This is fluid. This is ear. So what is this? This is the X-ray showing ear fluid level with lung is collapsed. So what is this? So it is a hydropneumothorax. Hydropneumothorax. What are the cause? Was this can be traumatic or tuberculosis or pneumonia or iatrogenic, it can be during the central line insertion. The other clinical feature present may patient may present with a respiratory distress, tachycardia, tachypnea. So investigation would be X-ray is sufficient to diagnose the hydropneumothorax. Treatment could be yes, we have to insert a intercostal drainage. ICD insertion. This can drain the fluid. So also this actually ICD is already inserted in this X-ray. So this is the ICD, intercostal drainage tube. It's on I. So this is the hydropneumothorax with the ICD. Again, what is this? This is in the next X-ray showing the what is this? This is complete only here is there, no lung field. So this is also pneumothorax and the treatment pay insertion of the intercostal drainage tube. Yes. So thank you so much. This is all about the general common X-ray findings which can be asked in the final year MBBS examination. So on the list.